So welcome everybody to New York. Thank you, Dr. Sharma, for having us back and doing this again. I scrolled down to advance. Okay. So I actually do have one disclosure. I have no financial disclosures, but I do have one disclosure. I'm going to be sitting with you this fall to research in my interventional board, so I'm right there with you. So without further ado, so here are the references I'll pose to you for studying for the boards. You know, we always say look at the guidelines, know the class 1, class 3s. So the 2016 guidelines on duration of antiplatelet therapy came out. This is a focused update on the background of the original 2014 update on the management of non-ST elevation MIs and acute MIs. But in reality, we all know we go to the Mayo Clinic review course, whether it's on DVD or the webcast. Those are outstanding references. And then also the question bank with the ACC, the CathSAP are also outstanding. So for your references, choose which one you want. So I do this talk purely questions. I think questions are the best way, the most high yield for everybody. So there's not going to be a lot of didactic talk here. So which of the following antiplatelets? So as a caveat, the boards love antiplatelet therapies and they love pharmacology with antiplatelets. So I'm going to try to hit some of that as well. So which of the following antiplatelet agents interact directly with platelet surface membrane receptors? Clopidogrel, prasugrel, aspirin, Vorapaxar, A and B, A, B, and D. Excellent. Very good. So by way of review, here's a schematic that kind of shows the various receptors we exploit with antiplatelet therapy. You have the P2Y12 receptors over here, very well known to everyone in this room, clopidogrel, prasugrel, ticagrelor, the thionopyridine and the non-thionopyridines, and the new kid on the block, cangrelor. The two B3a inhibitors, you may or may not know, these have really fallen out of favor in the IV form. The guidelines give it now probably 2A, 2B at best, but you can see where they work as well. These are membrane receptors. Aspirin is the only one that does not. Aspirin works through the cyclooxygenase, which is a tissue-bound enzyme. And the thrombin inhibitors also work on the thrombin receptor on the platelet surface. So just by way of review. Okay, all the following are true regarding ticagrelor except it inhibits the cellular uptake of adenosine via the sodium-dependent ENT receptor. It's metabolized to adenosine. It significantly increases coronary blood flow. It inhibits platelet activation via the A2A and the A2B receptors, whose genes are upregulated with ischemia. And there's an increase in serum creatinine with ticagrelor in patients compared to clopidogrel with Plato, or F, all the above. Someone yell something out. B? E. E is incorrect. B is correct if you said B. So B is correct. Ticagrelor is not metabolized to adenosine. So a lot of the benefit of ticagrelor, we think, what that Plato trial showed with the improved cardiovascular mortality is related to adenosine. And adenosine is not a byproduct of ticagrelor. All ticagrelor does is block the reuptake of adenosine through that sodium channel. So very important to understand that. It does not create it, it's not metabolized to it. And this is a nice schematic that shows what I was talking about, the benefits of adenosine. When you compare adenosine to ticagrelor, adenosine increases vasodilatation. Well, so does ticagrelor. Adenosine decreases ischemia reperfusion injury. So does ticagrelor, reducing MACE. Adenosine increases platelet inhibition. So does ticagrelor. So adenosine decreases the GFR, and those patients in Plato had a 10% rise in serum creatinine. So that's the mechanism of that. And as you know, adenosine also increases the shortness of breath and dyspnea. And what do you know? You all know about the 14% side effect of ticagrelor that's listed as a dyspnea. So a lot of the benefit and the side effects of ticagrelor are probably related to adenosine. Question 3. Which of the following statements are false? Platelet adhesion is mediated by the von Willebrand factor. Activation results from agonists that bind to the respective membrane receptors on adherent platelets and release prepackaged granules. Platelets are nucleated cell fragments released into the blood from bone marrow and regulated by thrombopoietin and have a short lifespan. Or platelet aggregation involves fibrinogen or von Willebrand factor binding to specific membrane receptors in the 2B3A complex. Yeah, so this is a gimme, right? You all know platelets are anucleated, so all the other ones are fluff. You don't have to know it, you just have to know what it's not. So, but here's a schematic that kind of goes through the stages of platelet physiology. We have platelets kind of rolling around, resting. They're anucleated, disc-shaped. And in the process or in the setting of an endothelial injury, the endothelial tissue expresses von Willebrand factor, which then causes platelet adhesion. And with adhesion comes agonist release and immediate platelet activation. That activation then forms cross-links, and you get aggregation. And this obviously, the time lapse here is within seconds. You form an immediate platelet plug. And it's nice to see this because you can see where the pharmaceutical industry has really targeted aspects of platelet physiology. We have platelet aggregation inhibitors, we have platelet activation inhibitors. We don't yet have a platelet adhesion inhibitor, but my understanding is that those are in the pipeline as we speak. Question 4. So this is a simple you know it or you don't. Which of the following 2B3A inhibitors has the shortest half-life but longest duration? Yeah, great. That's the one you want to know. This is the one they're going to get you on the boards. So really quick, small molecule and antibodies, right? Abciximab is an antibody, has a long half-life. The most important thing about abciximab is it's not reversible. You got to give platelets to reverse it. I'm sorry, it is reversible. You got to give platelets to reverse it. The other ones are non-reversible. You just let the half-life run out. Okay, very important. That's what they get you on, is giving platelets to a patient that's having bleeding on a 2B3A inhibitor, specifically abciximab. Number 5, again, either you know it or you don't. Which of the following drugs should have its dose adjusted in renal insufficiency? Argatroban, tirofiban, abciximab. Excellent. B. All the others are processed or metabolized hepatically. Argatroban, abciximab. So tirofiban is cleared renally. Good job. Which of the following mechanisms leads to an inhibition of platelet function following treatment of P2Y12 receptor inhibitors, such as clopidogrel? So this is a really in-depth pharmacology question. It reduces cyclic AMP, increases the vasodilator stimulated phosphoprotein, or VASP, inhibits PLC, inhibits adenylyl cyclase, or inhibits protein kinase C. No, it's B. So all the others. So the way ADP works is when ADP binds the P2Y12, it decreases adenyl cyclase, it decreases cyclic AMP, and therefore reduces the phosphorylation of VASP. When you inhibit that receptor, you're going to have an increase in AMP, increase in adenyl cyclase, and increase in the phosphorylation, which then by turn minimizes the platelet activation. So it's kind of opposite what you think. Number 7, which of the following best describes the reason prasugrel provides more potent and consistent platelet aggregation inhibition compared to clopidogrel? It's absorbed over a broader gastric pH range and is therefore less inhibited by proton pump inhibitors. The active metabolite is formed by a single oxidative step. The effect of foods such as grapefruit juice is lesser with prasugrel. Exactly. So this hits to the cytochrome P450 metabolism. We all know clopidogrel is a prodrug. It goes through a 2-step process, oxidation, to the active metabolite, versus prasugrel has a 1-step oxidation. That's it. That's why it's much more efficacious, or much more active metabolite formed with that. Single oxidative step. Very important. Okay, number 8, in TIMI-38 Triton, at 1-year follow-up, how did the occurrence of ischemic events and major non-coronary artery bypass bleeding events, so non-cabbage bleeding, compare with prasugrel versus clopidogrel? Decrease, decrease, no change, decreased, increase, no change. Very good. So you all know this slide. TIMI Triton 38. Prasugrel had a statistically significant decrease in the primary endpoint, but this came at a cost with increased bleeding events, non-cabbage bleeding, and intracoronary bleeds. So very good. Number 9. Which of the following statements regarding prasugrel is false? It's a third-generation thienopyranine and has a more potent, consistent, rapid inhibition of the P2Y12 receptor. In a pre-specified subgroup, treatment with prasugrel seemed to be less effective in subjects with diabetes compared to clopidogrel. It does not seem to be prone to altercations in pharmacokinetics or dynamics with clinical efficacy based on genotype. And in TIMI 38, patients greater than 75, less than 60 kilograms or prior TAA benefited more with clopidogrel versus prasugrel. Yeah, actually, you know what? You're right. D is wrong too. Okay, but let's talk about this one. Everyone knows not to give prasugrel with those things. Okay, in the pre-specified group. So this is a subgroup analysis of TIMI 38. When you looked at diabetes versus no diabetes, those patients with diabetes had a much more separation of the curves compared to the patients that received clopidogrel. And this was less so with the non-diabetic group. So there's definitely benefit in the diabetic population. And we found this actually similar with ticagrelor here at Mount Sinai. We did a pharmacokinetic study, and those patients that received ticagrelor had a much better antiplatelet inhibition with diabetics compared to non-diabetics. So very important. This effect of the prasugrel or ticagrelor was irrespective of the loss of function allele. You see these two bottom curves, the green and the blue. These are patients with ticagrelor with or without a loss of function allele. There was no difference. And the same with prasugrel. Non-significant, didn't matter. Number 10, in the platelet inhibition and platelet outcome trial, testing ticagrelor as compared with clopidogrel among patients with ACS, how did ticagrelor affect the rates of mortality and non-cabbage bleeding? Excellent. You guys know the major trials here. So the primary endpoint, everybody knows this, 16% relative risk reduction in primary composite death, MI, and stroke. And more importantly, there was a significant increase in the non-cabbage bleeding group. Okay. Number 11, polymorphisms of which of the following genotypes can modulate intestinal absorption of several cardiovascular drugs? ABCB1, P450, PIA, or vitamin K? ABCB1. This is the intestinal absorption. B, whoever said B, these are liver. So ABC1 is important. This is a P glycoprotein, the ABCB1, and it's very important with the clopidogrel metabolism. It is expressed in the intestinal epithelium only. Okay, proton pump inhibitors, such as omeprazole, have shown to reduce pharmacokinetic and pharmacodynamic effects of clopidogrel by modulating the effect of which of the following? 2B3A receptor expression, 2C19, 3A4, or P glycoprotein. So it's B and D. B and D. Majority of this is going to be through B. So this is the star 2 allele that we don't hear about anymore. The boards love it. This is the one you want to know that metabolizes clopidogrel. So speaking of platelet activation and such, which of the following guideline recommendations has been given for platelet function testing in clopidogrel-treated patients? Yeah, it's 2B. It's really fallen out of favor. We don't do it anymore, and the guidelines don't support it either. So here's a case, 76-year-old diabetic, hypertension, smoking, 2-3 days of chest pain, stable vital signs, EKG showed nonspecific changes, positive troponin. Renal and hepatic function are normal. Diagnosed with an ACS and taken directly to the cath lab showing a thrombotic large OM1 with TIMI2 flow. So which of the following statements are false as it pertains to antiplatelet therapy management? A personalized approach such as genotyping to select antiplatelet therapy for patients with ACS may reduce ischemic and bleeding events. A strategy of guided de-escalation of antiplatelet treatment is non-inferior to standard treatment with prasugrel at 1 year. HPR, or high platelet reactivity on clopidogrel, is associated with a higher rate of MACE post-PCI, whereas very low on-treatment platelet reactivity is associated with bleeding. Or post-PCI MACE rates are similar among clopidogrel-treated patients without 2C19 loss of function allele. D. Okay, so let's go through a couple of these. So this was the PharmClo trial. This looked at basically randomizing 800 patients with ACS to a standard of care therapy that we all do in the guidelines, giving antiplatelet therapy up front versus a pharmacogenetic arm. They tested them for a loss of function allele and got the result within 70 minutes. And based on that, they then put them in a specific treatment arm. And what they found out is that there was basically a non-inferior trial of genomic guideline treatment versus standard of care. So it may have benefit. The large trials are still underway, but there's some benefit, maybe some benefit in doing so. Tropical ACS was a Prasugrel inhibition, looking at giving Prasugrel up front and then de-escalating the antiplatelet therapy to clopidogrel. And this also was a non-inferior trial. And by de-escalating that that antiplatelet therapy 14 days out, you actually saw less bleeding, no change in clinical benefit, and no change in bleed, or actually less bleeding and no change in clinical benefit. So there may be some benefit in de-escalating therapy. And this was a large trial in 2017. The on-treatment platelet reactivity test. So when you're above 208, you're increasing your ischemic risk, and when you're below 208, you're increasing your bleeding risk. Those are the important things to know. And the IGNITE trial looked at if you had the loss of function allele, giving the alternative therapy, Prasugrel or ticagrelor, was better than giving clopidogrel with a loss of function allele. So these are some of the trials that are supporting it. Number 15, which of the following are true regarding platelet reactivity testing in routine practice? Utility of reactivity testing has been validated in randomized trials. Patients with HPR have a higher cardiovascular event rate. Increased clopidogrel dosing has been shown to reduce cardiovascular events. And switching from clopidogrel to Prasugrel or ticagrelor has been shown to reduce events in patients with HPR. Yeah. So none of the other ones are true. So this is basically a very snapshot. This is an old trial, but it really depicts basically the quartile of patients that are at that time termed clopidogrel resistant. We don't use that term anymore. But the higher quartile of patients that had antiplatelet reduced inhibition showed to have a higher ischemic event over here. So higher platelet reactivity, higher events after PCI. And you all know the variable causes of high antiplatelet events or platelet reactivity. There's genetic and non-genetic factors. We won't need to go through that. That's an old trial we won't go through either. Question 16, platelet aggregability is increased by numerous factors, including hypertriglyceridemia. Elevation of which of the following lipoproteins is associated with reduced platelet aggregability? So lipoproteins can affect platelet aggregation. B? No, A. A. Actually, HDL is the only lipoprotein that has been shown to increase decrease platelet aggregation. All the others are going to increase. The LDL is going to increase platelet activation. But there is a component of HDL. One of the HDL subtypes can decrease it. I'm not sure which one. 17. So clopidogrel and ticagrelor de-escalation. So here's a case, 76-year-old with chest pain, stress to abnormal stress test, underwent a mid-LAD drug-eluting stent. 1 week after developed shortness of breath. You concluded this is a result of a well-documented side effect of ticagrelor. And you discuss options for antiplatelet de-escalation therapy. So de-escalation therapy. Which de-escalation regimen is the most appropriate in this patient? Stop the Prasugrel and start clopidogrel. Stop Prasugrel and start clopidogrel 300 with a 300 loading dose. Stop Prasugrel and start 600 milligrams clopidogrel 12 hours after, or stop the Prasugrel and start clopidogrel 75 without a loading dose. Yeah, good. C. So this was a SWAP 4 trial that basically showed the red line is the one you want to see. Loading up front with 600 milligrams 12 hours after is going to drop your platelet reactivity much more than the other arms did. You still in the end come out below 200, but it's a better way to do this after stopping the more potent antiplatelet agents. And this is the control of continued ticagrelor here. So here's a de-escalation with Prasugrel. 66-year-old with chest pain, abnormal stress, stented to mid-LAD, put on dual antiplatelet therapy with Prasugrel and aspirin. 3 months had a bleeding event. So within 6 months, which de-escalation regimen is the most appropriate here? Stop the prasugrel, start clopidogrel 75. Stop the prasugrel and start 300. Stop the prasugrel, start 600. Stop the prasugrel and start clopidogrel. So it's interesting. This one you don't have to load. So when you go from, so the prior question, the answers were prasugrel. They should have been ticagrelor. I realize that. This one is prasugrel. So when you go from prasugrel to clopidogrel, you don't have to load, okay? Because they're both ADP. They're working on the P2Y12 receptor. It's very important. And my good friend Dominic Angelito came up with this expert consensus. It's a really nice document, clear as can be, on how to switch antiplatelet medications amongst all three. This was published as a consensus in 2017. So you can see here, when you're going from prasugrel to clopidogrel, they recommend just starting 75 milligrams, 24 hours, the last prasugrel dose. Really simple. The more common one we use, or I use, is going from ticagrelor, because of the shortness of breath, to clopidogrel. That's when you have to load. So most of the cardiologists in the interventional world know this. It's the non-cardiologists that don't. In the office, they'll call, they say, we'll just put them on 75. And if it's a recent stent, they're going to have stent thrombosis. So make sure they load, and they load with 600. And then 19, which of the following statements is false regarding non-STEMI? The proportion of ACS in patients worldwide who are managed medically without revasc is about 40 to 60%. An early invasive strategy is indicated in initially stabilized non-STEMI patients who have an elevated risk for cardiovascular events. In unstable angina, patients treated conservatively compared to clopidogrel, prasugrel significantly reduced the frequency of death. Yeah, exactly. This is Trilogy. Trilogy compared patients with ACS, non-STEMI, treated medically, not going to the cath lab. They had a higher bleeding risk compared to clopidogrel in blue. So this is not what you want to do. So the primary endpoint of bleeding was significant. So the last one is the Champion Phoenix. This is the new kid on the block. Not so much new anymore. I think most people in the room have used IV Cangalor. It is an ADP receptor blocker. It has the following effect on stent thrombosis and severe bleeding, respectively, compared to clopidogrel in the Champion Phoenix trial. D. So it decreased stent thrombosis, but it increased the bleeding. Okay? So I'll just remind you, this is the most impressive graph I've seen in platelet reactivity and platelet concentration. Is you shut that platelet, the Cangalor, off, the concentration drops. The minute it drops, within 20 minutes, your platelet activity goes up. So this is a niche drug that's really been approved for perioperative antiplatelet therapy. We use it in non-STEMI and STEMIs a lot because these patients in cardiogenic shock are not going to absorb antiplatelet. Or as you know, if they vomit the antiplatelet pills up, we reach right for IV Cangalor. And the important thing is it has a very, very short half-life. Best of luck to you.